Welcome back to Shared Practices. This is episode 3 of season 4. We have phenomenal guest today who is known for a long time for his expertise on our whole season. This season, we are doing case acceptance. We are talking about increasing our ability to do more dentistry for our patients. And we have with us today, Dr. Paul Homoly. And George, where did you first hear of Dr. Paul Homoly? Do you remember?
Actually, yeah, I do. Not related to case acceptance, I guess, very much. But Scott Luna's Not the Average Startup Threads,
Okay.
like his first claim to fame on Dental Town, he talked about how he read a lot of Paul's books. That it's what's it called? Anyway, a lot of his books, and he mentioned a few of them. Main one in that thread, and I went and got it, read it, and then I watched his CE on Dental Town, I believe.
Nice. For me, I think it was first when T-Bone mentioned it on either my episode that I had him on the podcast or one of his episodes. He goes back and rereads and re-listens to Paul Homoly every single year. So he has long been known as one of the industry giants that has developed expertise and courses and just phenomenal content around this idea of getting patients to say yes. So we were so excited to get him on the show. He has built a course around this online and in person. I think I'm actually considering going to one of his in-person courses for teachers and presenters. So he's got a whole nother line of courses for people who present and teach and have podcasts. And there's actually, if you go on the website, you can see a bunch of the podcast people who've been on there who have their own podcasts and have seen benefit from that. But this was great. Having him on the show was like being able to pick the brain of like one of your favorite CE presenters. So it's probably one of my favorite parts of having a podcast is getting personalized CE for free. Sorry, guys, you didn't get to be in on the interview, but I absolutely loved having him on the show. Phenomenal guest. I'll stop bragging about it. Let's just go straight to this. Here is Dr. Paul Homoly. Dr. Homoly, welcome to the show.
It's great to be here, Richard. I've enjoyed the conversation we had just before we went on the air about your podcast, Shared Practice Podcast, really targeted at the younger dentists, helping them, giving them the confidence to go into private practice. So good for you, Richard.
Well, thank you. We are so grateful that you're here on the show because we're doing a season on case acceptance, and you are the man when it comes to case acceptance. You've got years of experience teaching this and leading other dentists and shaping them. You've got books. I've been listening to, you've got one on Amazon, I think, of a workshop that you did is phenomenal. You've got this whole audio book on Amazon for, I think it was like $10. It was very, very, very affordable and gave me a fantastic taste of what it would be like to take your full course. So you've done the books, you've done courses, you've trained dentists. This is your area of expertise. So super grateful to have you on the show. Thank you for being here.
Outstanding. Well, it all started. I graduated dental school in 1975. I served 2 years in the United States Navy as a Navy dentist.
Well, thank you for your service.
Oh, yeah. Well, you're welcome. You're an Army dentist, so that's very cool too. And as we were saying earlier, you don't learn a lot about practice management when you're in the military. You learn a lot of clinical skills. You get your confidence up. But as far as running a dental practice, and especially as far as influencing patients to accept care, that really doesn't exist in a military style practice.
They have to be there. They are required by their first sergeant, their chain of command. They drive. Right now I'm at a Fort Sill, which is a training post, and they literally are bussed over.
Okay.
Dropped off, and they can't leave until they get their dental treatment done, and then they're taken home. So my case acceptance is phenomenal right now. I'm hitting 100%.
I love it. And that's the way it was for me, too. I was stationed at Marine Corps Air Station Cherry Point as a Navy dentist. And, the Marines would hop in the chair and away you go.
Yeah.
But, all that ends with private practice. And, I learned early on that there are a lot of misconceptions about the whole case acceptance process. There are some limiting beliefs that accompany the case acceptance process. And I understand, Richard, the primary listening audience for your podcast is generally the dental student or the younger dentist or the dentist who's been out of dental school for a few years.
Yep.
And I would say that one of the leading limiting beliefs is that patient education, that is sitting down with the patient and educating them is the driver of case acceptance. And when I say it's a limiting belief, what I mean by that is that you can educate a patient all day long. And if they're not ready for care, or they don't understand why they need to care, or you as the provider don't understand why they want care, then the whole educational process becomes far less effective than we would like for it to be. We went through dental school, and, in dental school, we had to sit down and explain to patients, here's what we're going to do, here's why, here's how you got this condition, here are the different steps that we're going to go through. And ultimately, you graduate dental school, you get into private practice, maybe you read a couple books on case acceptance, or you take some courses. And boy, I remember when I first got out of school, I attended all this CE, especially on practice management. And what we'd hear time and time again is educate, educate, educate. And I believed it, because these were successful dentists. I wasn't. They were. They had nice cars and nice practices. I didn't. So I figured I'd follow their lead. And it took me maybe 5-8 years to realize that the education process is effective when the symptoms or the conditions in the patient's mouth are not so severe. For those modest care patients, Richard, for those patients whose total care needs are maybe no more than 2 or 3 restorative units, whose total case fee is less than $3,500, sure, patient education makes sense. Here's why. For modest care patients, for patients who don't have severe conditions, oftentimes they're not aware of the conditions. They're not aware at all. Patient hops in your chair. You ask, hey, how can I help you today? Well, I'm fine. I just need an exam and a cleaning. You say, you got any problems? Say, no, I'm fine. I've been to the dentist. I was to the dentist a few years ago and didn't have any problems. Well, you look in the mouth, they got periodontal disease, asymptomatic periapical abscesses, class 2 decay, impacted third molars. So you show them the x-rays, you say, look at this one. They say, wow, I had no idea I had these issues. So in what that does is that through the process of education, Richard, we have created concern with the patient. So education creates concern. Concern becomes the influence for them to accept care, either part of it or some of it later. And generally speaking, modest care patients, they're more or less ready for care, more or less. They're going to get something done, because it's not a life-altering event for them to get their teeth fixed. It generally fits within their budget. If it doesn't, they can always stretch a credit card or a care credit payment or something. It's not a big time commitment to them, because, how long does it take you to produce, a couple $1,000s worth of dentistry? Not long. So it isn't like they need to spend, months in your chair. So the treatment fits better into their life. So the educational process is valid for the modest care patient.
And you said, and I'll stop you here real quick.
Sure.
You said that the modest care patient you'd kind of classify as that, like 3,500 or below, needs-based, here's disease, here's the problem, let's fix it. That's the kind of dentistry we're talking about here.
That's right. And the jargon in dentistry is bread and butter dentistry. That's the deal. And most young dentists getting out of school, that's what you're going to be most comfortable with.
Sure.
And that's a good place to start. And it's smart to do that. You can become a safe starter in private practice or in any practice by focusing on that bread and butter patient. However, as dentists mature, as you mature into practice, you'll begin to get a little burned out on the bread and butter. 2-surface composites won't be sexy for you anymore. Seeing kids gets to be a bit of a drag. And one day you'll reach a point where you'll say to yourself, well, I need something a little more out of my career. So you run off to one of the restorative institutes like the Dawson Center or the Coy Center, and you start learning the concepts of complete dentistry. You become more up to speed with occlusion, TMJ, airway, aesthetics, phonetics, all of the full mouth reconstructive principles. And a lot of it's very exciting, to tell you the truth, to begin to see and understand diagnosis and treatment plan beyond what you've learned at dental school really rejuvenates. I know it was rejuvenating to me. I attended the L.D. Pankey Institute. I went through all of its early curriculum. I did all of the Dawson Center curriculum. I did all of that within my first 5 years of practice. So
oh, wow.
I came back from these institutes just all fired up. Now, when I would look in a patient's mouth, I would see things that I wouldn't see before. Consequently, my treatment plans were more complete. And my treatment plans went from $2,500 to $5,000, $8,000, $10,000, $12,000.
Sure.
And that's where the crash and burn create, right there. Because the dentist and team have the verbal skills and the behavioral skills to influence patients for the modest care patient. Because there it's just, here's what you got, here's what you need, what do you think, right? It's not that big of a deal. However, when the fees get up there $8,000, $10,000, $12,000, everybody gets sticker shock in the practice. The patients get sticker shock. Sure as heck, the chairside assistant gets that sticker shock. Oftentimes, the treatment coordinator, she's drooling when she sees the fees. And frankly, for a lot of young dentists, a $10,000 fee is more than they could pay for their own care. So it's kind of a thin ice situation. Richard, my work is all about how do you present complete care to patients without losing them to sticker shock. See, that's the real deal here. We have, when I think about it, it is better now, it's safer now for the young dentist to do more complete dentistry than it ever has.
Why is that? So why do you say that?
Well, number one, you've got dental bonding, right? Dental bonding. We didn't have that even 15 years ago. You've got CAD/CAM in digital imaging, which is just absolutely terrific for implant paste placement. You've got surgical guides. You've got 3D imaging. You've got airway analysis. It is much easier to get a safe start in comprehensive dentistry now than it's ever been before. However, what has not progressed are our verbal skills and our behavioral skills in order to influence patients to accept a 10 or 12 or 15 or $15,000 case or greater.
Yeah.
And the trap that dentists fall into, that I fell into, is that the case presentation process for this, let's say this $15,000 case, was simply a narration of the treatment plan. We'd present a $15,000 case the same way we'd present a $1,500 case. Here's your problem. Here's all my solutions. Here's the benefits, the risks, and the options for treatment. Well, if you do that with a $15,000 case, everybody gets sticker shock. The patients get confused. And oftentimes, patients will abandon a practice because they're shocked or they're embarrassed about the fees. So what happened to me and what happens to many dentists is that when they come back from the institute and they learn all of this great stuff, they start offering to their patients. But, after, half a dozen or a dozen patients saying, wow, I had no idea. I'm sorry, but I need to go home and think about this. And they leave and they're gone forever.
Right.
All that has to happen is about 8 or 10 times. And dentists begin to get powder burns on the thing. And what happens is, and I did this too, is they pull back on the treatment plans. They don't treatment plan comprehensively, but rather they offer patients what they think the patients can afford. And that is the trap right there. You see, there's a dilemma here. And I'm speaking specifically to the young dentists right now.
Yeah.
They need to get this, is that, number one, if you present care in such a way that you do not reveal all the conditions, you do not reveal the consequences of those conditions if left untreated, you are in direct violation of the state dental boards and dental ethics.
What do you mean by that?
Well, let's say you see a patient that's got impacted third molars,
sure,
or periodontal disease, and for whatever reason, you don't reveal that to the patient. The patient says, well, can we just fix these front teeth? You say, fine, you fix the front teeth. And you don't do a complete exam, nor do you offer complete care. So now that patient has been examined by you, you in your examination are required to reveal those conditions and the consequences.
Diagnose and share with the patient what they have.
Absolutely. The state dental practice acts are very specific about that. Here's the dilemma, though. If you do present all of the care, but you present it in such a way that you embarrass or shock the patients, now you lose the patient. So it's kind of you're damned if you do and damned if you don't.
Sure.
My work is all about how do you present complete care to every patient who's had a complete exam. How do you present that care without losing them to sticker shock? They may not be ready for care, Richard. Understand that probably fewer than 5% of patients whose total care fee is greater than $10,000, fewer than probably 1 or 2% of those patients in most practices would be ready for care.
And are you saying ready for care if the average dentist presented it, or are you saying ready for care even if it's presented perfectly?
Even if it's presented perfectly.
So the case acceptance on this isn't necessarily going to, if you're presenting 10 of these, you're not going to necessarily have 10 cases that say yes. Maybe you've got 2 or 3 if you're doing everything right, but the key is to not lose the rest of your patients in the process. Is that what you're saying?
That's exactly right.
Okay.
The trick is for patients who are ready for this type of care, who have the budget, who have the time, where the condition is a life-altering event for them. They can't speak, their digestion is poor, they're having health-related issues, they're having intimacy-related issues. And we call those issues disabilities, how the condition affects the patient's life. The patient is the budget, patient is the time, and the patient is experiencing significant disability. They're more ready for care. Now, most patients don't have those 3 lined up. Most patients may have disability, but they may not have the time or the budget to complete care. The trick or the secret or the outcome of case acceptance is to present care, complete care, Richard, in such a way that even though the patient may not be ready for care, they'll never forget how well you offered it. And when they become ready, they'll choose you to do it. So by retaining these more complex care patients in your practice, and they would basically be in the recall aspects of your practice, keeping these patients in the practice until they become ready is absolutely mandatory to developing a complete care practice down the road. Does that make sense?
Absolutely. No, that framework, it also takes some of the pressure off in that you don't have to feel like you're a failure if you're presenting comprehensive care and patients are saying no at the time. If you've left the door open and made it a positive experience rather than a awkward, confrontational, pressure, weird experience for the patient and for you. So I think it reduces the stress level around the whole process as a provider.
It sure does. And one of the disservices done by the practice management domain of thinkers, the thought leaders in practice management, some of the disservice there has been, well, if the patients aren't accepting your care, you didn't educate them well enough. I totally disagree with that. If education was the key to changing behavior, then each of us would have ideal weight, perfect blood chemistry, fully functioned pension plans.
Yeah.
Education is not the big trigger to patients' behavioral change, especially in a dental practice. It has to do more with, does this care fit into their life right now?
Right.
And educating a patient doesn't change their life circumstances. If they've got a couple of kids in college, you educating them to mesial drift and internal pterygoid spasm isn't going to change that.
Yeah.
It doesn't change it at all. And here's one of the problems, Richard, if a dentist doesn't acknowledge or recognize that there's life circumstance issues, we call those fit issues, how it fits into the patient's life. If the dentist and team don't recognize the fit issues involved in these complex care cases, and they continue to beat on the patient with patient education. You need to get a bridge. 6 months later, they come in. You need to get the bridge. 6 months later. You need to get a bridge. 6 months later. Patient yells, "Don't talk to me about the bridge."
Mm.
And you write it in the record. Don't talk to the patient about the bridge. Next appointment, broken appointment. Right?
Yeah.
We educate patients out of the practice. And what I would say to you is the education process needs to be titrated appropriately with the complex care patient. Educating patients in the presence of significant fit issues oftentimes feels like sales pressure.
So let's talk about this a little bit more. So you're saying fit is the idea of, does this care fit into their life, their budget, their
work, their health, their family, everything that's going on in their life? How does it fit?
So how can a dentist, obviously you go into this in your course quite a bit, but how can a dentist incorporate that idea in their case presentations? And what can you say to help patients understand that you realize they've got things going on in their life and that you want to make this fit in their life? What are some things that a dentist could say?
Well, it really starts not with what the dentist say, but it's what the dentist asks. You see, and this goes back to now the process of case acceptance. Typically, here's what I see. And I'm speaking from 30 years experience watching hundreds of dentists present care and through the entire new patient experience. Patient walks in the door. They hand off the paperwork or they fill out the paperwork. Then the dental assistant comes out in the waiting room, says, "Okay, it's time, Richard. Let's bring you back." They bring you back. They put you in a chair. They shoot a mouthful of x-rays. Hygienist comes in, cleans your teeth, charts the pathology, talks to you about home care, does a cleaning, rings the bell. In comes the doctor. Doctor looks at the hygienist charting, talks to you. "Yes, I see this. Yes, I see that." And then dictates to the chairside assistant, "Here's our treatment plan. We need crowns on 30 and 31. We need 2 surface composites on 4 and 5, blah, blah, blah." Right?
Yeah.
Then it shakes your hand and walks out. Now, okay, that process that I described right there is in place in so many dental practices that are just stuck. They're just stuck because the patient, I mean, what do you know about the patient?
Nothing.
Nothing, absolutely. So the process that I teach, and this is especially cool for young dentists to learn, is number one, start the relationship before you start the diagnostics. So now let's do a different scenario. You're the patient, Richard.
Okay.
You walk into the dental practice, you fill out the forms, dental assistant comes and gets you and says, "Come on back. You're gonna meet Dr. Homoly." They bring you to a talking area, not an operatory, but a talking area. And you sit down, and you walk into the room, and who's there sitting waiting for you? I am. I go, "Richard, hey, welcome to the practice. Hey, I'm Dr. Paul Homoly. How can I help you today?" And now you and I are going to have a conversation. Okay. Well, you're going to say to me, "Well, I don't like this tooth. I don't like this tooth." And you say, "And these 2 front teeth, they've been chipping and, I had them filled years ago, but the filling's now dark. And I don't know. I was hoping you could do something about that." I said, "Well, tell me more about that, Richard. What is it about those front teeth that bothers you? Is it an issue at work, or is it an issue in your personal life? Tell me how this gets in your way. What's going on now that makes this important for you?" Well, you go, "It's a funny thing. I'm an IT specialist, and opening has come in my office right now, and there's a chance for job advancement. And to tell you the truth, I want to look better. I want to be more confident in my appearance because I'm going to be dealing with some people." I said, "Well, terrific. I understand it. My son's in computer science," and I'll start talking about my son. Okay. But what you just did is you revealed to me the behavioral benefit, not the clinical benefit you're looking for, but you revealed the behavioral benefit of what you'd really like to have done. Now, let's just take that conversation, what we learned from that conversation.
Go back and kind of, because sometimes it's hard in an audio format, people are driving and doing other things, but the question that you could ask, if I can try and rephrase it to make sure I understand, is how does this affect you? So they've said, what's bothering you? They say what's bothering them. And then you ask, how does this affect you in your day-to-day life? Or when have you noticed this is a problem? Am I getting the question right, or am I missing some nuance?
No, you're in the ballpark. It's all about how this condition gets in their way.
Okay.
You may even say that, Richard, how does this get in your way? Is this a problem more for you at work, or is it a personal issue?
Okay.
Or I might say, well, tell me about a time where this bothered you, or tell me when you first noticed this problem.
Okay.
You see, when you ask questions like that, that encourages the patients to tell a story. Well, I'm in IT and I do this. See, it's about listening. It's not about educating patients. See, this is where my work breaks off from the whole patient education track. Let me be quick to say we are going to educate patients, but not to begin with. So after I learn what your behavioral benefit is, well, I'm up for this promotion and I really like to look better. I said, well, terrific. Richard, I'm looking at your record here. I see you work at Zenith Radio. Did your wife work there too? Well, no, she's a stay-at-home mom and this and that. Really, how many kids do you have? Well, we got 3 kids and she's expecting our 4th. Well, I've got 2 kids. And so now I start talking to you about your personal life. Now, I know if you got 2 or 3 kids, family matters are always the leading source of fit issues.
Okay. You
got childcare, you got housing expenses, school, all of that stuff. As the kids get older, they get more expensive. You'll soon discover that, my friend.
Yeah, we're at the 3-year-old and 5-year-old, and I can see it coming. They're both girls.
Oh, they're both girls. You're going to have to get off your wallet here, buddy, pretty soon. Absolutely. Yeah. Okay, so now I learned what your condition is, your 2 chipped front teeth. I know what your behavioral benefit is. You want to look great for your job interview. And I understand something about your fit issues now, don't I? Okay, now let's get to now I do your examination. I put a treatment plan together. I'm going to sit down and I'm going to talk to you. Okay? This is how it sounds. Richard, now that I've had a chance to, look at your teeth, I can see why you're not happy with those front teeth. And I feel really good about our ability to get you confident for your new job interview coming up. I get that. That's important to you. I also know that you've got a lot going on right now. You've got some young kids at home, and, I've raised families myself, and I know sometimes that, young families get budgets they need to stay within. Right over here, and while I'm doing this, Richard, I have my treatment coordinator in the room with me. I say, Richard, this is Joy, my treatment coordinator. Her job is to be your advocate in all of this. She can help you with the insurance. I see you've got XYZ insurance. Joy is really good about helping you get the most benefit from that. You're going to have an opportunity to talk to Joy and figure out how we can make all this best fit for you. Richard, as far as the 2 front teeth, I'm going to suggest that we replace that dark and chipped enamel with a new enamel-like material. It takes about 2 appointments to do it. For those crack fillings in back, I'm going to use a very similar material to restore those teeth back to the original shape and size. Now, I know there's one thing that you're not concerned about at this time. That's replacing that missing molar on your lower left side. I understand you said to me that it doesn't show when you smile, and frankly, you're more interested in the front teeth. And I understand that. I want you to know, though, that I am concerned about that. And when you're ready, my recommendation would be to replace that tooth in a way that, well, you'd be able to brush it right in your mouth. Richard, what questions or comments do you have for me? And at this point, we have a dialogue. Now, let me ask you something. How do you think this style of case presentation would appeal to most dentists? Dentists. How would that style appeal to most dentists?
I think that they could be taught to do that, but I think it would take some work to make that be it'd be a lot more comfortable than saying, here's this, are you going to do it or not?
Right.
I think as a patient, that feels a whole lot more comfortable than just MOD jargon. Here's your treatment plan.
Right. My experience is that most dentists, when they hear me do that, they go, boy, I don't know about that. You don't educate the patient. You don't give the patients options in treatment. And what about consent and all this stuff? And that's true. I did not present options. I did not present consequences. That will come later in this conversation. But here's the point. How does this style of case presentation, do you think, appeal to patients?
A ton more.
A ton more. And so here's the question. What is case presentation designed? Who is case presentation designed to appeal to? The dentist or the patient?
Yeah.
See, that's our blind spot. We present care in a way that appeals to us. And frankly, I liked telling patients how much I knew. Come on, I invested a ton of money and a ton of time in continuing education, and I'd sit down with a patient and I'd have that articulator out and I'd have their models, and boy, oh boy, away I'd go. I would describe to them the Pankey-Mann-Schuyler philosophy of occlusal reconstruction. I would actually say things like that.
Wow.
And I would
make you look really smart.
It'd make me look real smart. And in some ways, I thought that's influencing patients to show them how much I knew. And the reality of my case presentation wasn't designed for the patient. It was designed for me. And it took me 10 years to figure that out.
I think if I could comment here, I think part of the issue is also how we're taught to treatment plan lends itself, we're taught to do disease control and focus on perio and these other things first, and then address, other needs later down the line. And so if we started the conversation by saying, well, before we talk about anything, we've got perio, we've got this issue, you can be talking for 5-10 minutes about all this treatment that the patient needs before you even get to what they care about or what they came in for.
Exactly. Here you come in because you're concerned about this job interview coming up. And I tee off on you and say, well, before we talk about the front teeth, you got these impacted third molars. I see, advancing gingivitis. You got 4 and 6 millimeter soft tissue pocketing in your posterior teeth. So we're going to need to put you through what we call scaling and root plan. I'm going to introduce you to hygienists. Here, sit down. Let's watch this videotape on periodontal disease.
Nice.
You see what I'm saying? You see how there's the flip side of educating patients is understanding them. And my focus is on how do you understand patients? We already know how to educate patients. That's not a problem. The problem is what behavioral skills, what listening skills do dentists need to truly understand people? Now, here's the rub. If there's anything that young dentists need to learn, it's what I just said. It's take the time to understand people. Use the skills, some of the techniques that I brought out right here. If you've got a bunch of student debt, then you need to make the cash register ring. In order to do that, patients have to see you as their advocate, not as their educator. They can go online and get educated to dental disease. That's no trick. It's no trick anymore. Information and education has been commoditized. 30 years ago, people had to go to physicians and dentists to get healthcare information. Now they go to web.com or med.com or one of the thousands of health-related websites that will show how to do an implant, how to do cosmetic dentistry. You can see videos on hip replacements. Come on.
Yeah.
Information is commoditized. What isn't commoditized is that sense that the patient feels they're being understood and being well cared for. They don't teach you that in dental school. They don't have time to teach you that in dental school. The dental school has got enough on its plate without that adding to it. Does that make sense, Richard?
Absolutely. So understanding the patient, what they care about, their life circumstances, and acknowledging that as part of the discussion, as part of the treatment plan, is going to help to not make it feel so pressure filled, not feel awkward. It's going to help patients accept that. But, so what if they say, well, no, I can do this, but I can't do the rest of this. Do you just have them the treatment plan there in the chart, and then you kind of bring it up in the future in the same way with kind of acknowledging fit every time they come back?
Yes, exactly right. So you say to me, well, let's go ahead and get the front teeth and we'll worry about these missing back teeth later. I say, I understand, Richard. Let's go ahead and get this done for you. And then on every recall, we'd bring that up. I would say, Richard, how's the kids doing? How's the family?
Sure.
Hey, in light of that, is today a good time for us to talk about those missing back teeth? Or do we want to focus on getting your teeth cleaned today? What would be best for you today? And you know what? You keep that up forever. Forever,
Yeah.
right?
Yeah.
People need to get ready at their own rate. And as young dentists, most young dentists are going to see patients who are plus or minus 5 years of their own age.
Sure.
That's just the way it works out. And, in that age group, that's when you're young families, you're buying cars, you're buying homes, you're trying to build a practice, you're trying to get some altitude. You're like an airplane. It's just lifting off. The last thing you need is a lot of drag. And drag is going to be that transactional drag from student debt and all of the family expenses you've got.
Yeah.
If there was ever a time for dentists to learn the distinction between educating patients and understanding patients, it's when they're young. And you know what's interesting about this? I hear this comment from young dentists a lot. Well, I'm pretty young, and I hear, especially from women dentists, some women dentists look so young, they look like dental assistants. They'll say, I'm pretty young, and patients really don't take me serious, and how can I be, more influential, and these people are 30 years older than them. Here's how you do it. What you do it is you spend time being interested in your patients, not their teeth, but interested in them personally. Let them, ask questions about their family and their home life. Then reveal some of you. Let them know a little bit about you. Now, there's a boundary between being overly disclosing too much, obviously.
Sure.
But if young dentists want to, I'm 69 years old, Richard. I am the perfect candidate for full mouth. If I had a bunch of restorations of my mouth that were failing, I'd be the perfect candidate for full mouth restorations. Here's why. It fits. I can write the check. I've got the time, right? What I want is a provider. I want providers who are smart and sharp and upbeat, right? And your generation has the influence on our generation of being high tech, of being computer savvy, as knowing all the new and right stuff. Strut that. Let people know what you've studied, what you know. But you can't be a geek about it. Okay? That's where the millennials stub their toes. They get geeky about it. Don't be geeky. Be personal about it, and you'll do just fine.
So instead of talking about the 150 or less micron margins on your CEREC crowns, talk about the fact that it's going to take them 2-3 hours, and they're going to be in the chair, out of the chair. They don't have to come back.
No, you don't even need to say that. All you need to say, when we're done, you're going to look great for your interview. Understand, dentists want to explain their process. Stop that. Start talking about the outcome. The outcome is looking good for the interview. Now, during consent conversation would come after that case conversation that I role played with you, with the 2 front teeth and missing tooth. After we settle on what we're going to do and why, and you understand what the fees are, you've made financial arrangements with my financial coordinator, then I would sit down with you again at the same appointment, Richard, and I would say, well, terrific, Richard, we're going ahead with the front teeth. We're going to do a couple of fillings for you. Before we start, I'm really required by state law and by dental ethics that you understand the benefits, risks, and alternatives to treatment. This is just like going into a hospital and getting an operation. I'm required to let you know what could happen. And now I would do a traditional case presentation. Here's your problem. Here's how we're going to fix it. Okay. Do you see that?
Yeah.
I'm still educating. I'm meeting all of the standard of care requirements of informed consent. But what I've added is an additional step called influence. And boy, that's a big deal.
So this is fantastic. You talk about in the audiobook that I've been listening to, you talk about the difference between disability and condition.
Yes.
I loved the example you shared about your brother and his what you could call a condition, but to him is definitely not a disability. So talk to us. I think this kind of fits in this conversation of disability versus condition and how we can keep those clear and separate in our minds.
Yeah, condition is the biological entity that's outside of normal limits. It's the chipped tooth, it's the missing tooth, it's the disease. The disability is how that condition impacts the patient's life. For example, my brother Guy, he's got a distal incisal fracture on tooth number 10. He fractured that returning the kickoff against the Dallas Cowboys. He was playing with the Cleveland Browns at the time. Now, there is a condition, right? But you don't dare fix that.
Did you have this conversation? Because I want to know how this went down when you brought up to him, I can fix that for you.
I never said it. Okay. I never offered it. The hell no.
You knew.
He'd stop me in the ground. No. Yeah. You see, patients can have conditions with no disability at all. In fact, no symptoms. You see it every day, don't you? Patients have conditions with no disability. However, there are patients who have conditions with significant disability. So patients without disability, we have to educate them into disability. We have to tell them, Richard, you've got gum disease, you got gum infection around your back molars. I know you don't know anything about it. Let me show it to you. Then I would demonstrate it to you. I would show you an x-ray or a photo or on a model or in your mouth. Then I'd say, this condition, many patients have conditions just like this. We see it every day. And typically, if it's left untreated, patients find that the bone around the teeth can die. The mouth odor can get just really poor, and that infection can spread to other areas in the mouth. Does that concern you at all? Is that something you'd like to talk to me about? Now,
Yes, yeah.
But there's plenty of patients would say, well, I'm okay, but I'm more interested in my front teeth. Right. They may push back on it. But you see, it's not our role to get them to accept care. It's our role to understand them. They accept care based on their fit issues.
So, and I remember you making a point of not talking about, if you don't get this treated, you are going to lose these teeth, or you are going to, experience this. But you kind of reference it in almost patients with this condition experience X, Y, and Z.
Right.
Why do you phrase it that way specifically?
Because it's more evidence-based. See, if I talk to let's say an older patient, let's say a patient in their mid-50s, and they got 4 and 6 millimeter pockets around their teeth. How long do you think they've had that pocketing?
Probably a while.
Probably a while. And so here you are, young dentist or young hygienist, you come swooping into the room and say, boy, if you don't get this fixed, you're going to lose your teeth. And you've had this condition for 25 years. What does that do to your credibility?
Well, they're like, I haven't lost my teeth so far.
That's exactly right. It reduces your credibility. However, what if you said, I see this infection in a lot of patients, and in many patients, if left untreated, it can lead to tooth loss. You see, I haven't threatened you with your own condition, right? Because conditions will, progress of conditions will vary based on host factors, local factors, diet, nutrition, all that stuff.
Absolutely.
So an evidence-based point of view is more credible. And what it does, it showcases your experience and your wisdom. So and hygienists are the ones that have a big problem with this, because they'd rather take a fork in the eye than let a patient out of the office with, if we don't get all of it, you're going to lose your teeth. That's not true. What we'll say, it's important to have your teeth cleaned regularly, because when we see patients that don't make the patient the victim of this stuff. Now, if there is a life-threatening condition in the mouth, like oral cancer, I go right at it. I'll say, Richard, I'm looking at this lesion right here, this sore area. See this spot right there? That could be oral cancer. I'm going to call Dr. Bamber. He's an oral surgeon. He specializes in this area. Let's get you over to his office today. I won't fool around on something like that.
Sure.
But for most conditions, I've seen conditions like this, Richard, in other patients. And generally speaking, if they don't do anything about it, like your 2 front teeth, patients with darkened front teeth, typically, if they don't do anything about it, the teeth are going to just continue to darken in time. And I know that's your main concern. Now, I didn't say that your teeth are going to darken. I said most patients, and that is a very strong platform to work from.
Do you also discuss and say that most patients end up doing this treatment? Do you kind of use that kind of influence of others to say, this is what most of my patients end up choosing?
I really don't, because when I voice it, many patients who have this condition, if it's left untreated, leads to this. Does this concern you? If the patient says, yes, it does, then fine. Then I'll say, well, terrific. Then we'll sit down and we'll talk about how we can help you with this. Okay. I understand. They say, well, I'm really not interested or not concerned. I'll say, I understand. When you're ready, I want you to know that I'll be here. And then I'm going to enter it into the record that the patient is informed of this condition. Remember, patients need to know all conditions, all consequences if left untreated. That way you can do this stuff without losing the patients to sticker shock. That's where we started. Remember that?
Yeah.
All of this is to enable dentists, especially young dentists, to be able to present complete care with no fear of losing the patient. And boy, that's a big gift. That's a big gift. Listening to this podcast, Richard, can be a big gift for them. And I suggest they listen to it a couple times, because I've been talking pretty quickly here to get in a lot of content. So listen to it a couple times.
Well, and Absolutely. And I would go to, you have an online course that I was looking at here called Making It Easy for Your Patients to Say Yes, which is the same name as the book. And I think even on Amazon, let me see, Making It Easy.
That's right. It's making it easy for patients to say yes. It's an online program designed for in-office study. It's a series of videotapes. It's very affordable. I designed it in mind for the younger dentist who really wants to get a head start and is not really ready to lay down a couple $1,000s and several days out of the office to learn this stuff. I would highly recommend get involved with the online program, get your cash flow up, get your confidence up. And then when you're ready, then check me out for, live workshops.
Well, absolutely. This looks fantastic. I love that you have it both streaming, you have your audio as well if people want to do some on-the-go learning, because that's always one of my pet peeves is if I purchase a video course and then I can't sit down and listen to or watch the videos, but if you have the audio companion version of it, and you've also got your live monthly webinars, it looks like a lot of amazing, kind of very accessible content for
Sure.
dentists.
When dentists approach me at meetings, when I'm speaking at an association meeting, they'll say, well, I'm familiar with your work. I said, well, did you read the book? Did you watch the video? Most people will say, oh, I listened to your audio programs driving in the car. Yeah. So that's why I offer those MP3 audio downloads. So people, as they listen to your podcast, they can listen to the audio portion of the case acceptance online program.
Perfect. Well, thank you so much for coming on the show and sharing just a little bit of your knowledge around this topic. This is why we wanted you on. It's also why we are doing an entire season on case acceptance, because it's a skill that we need, that we haven't been equipped with from dental school and from just our natural experience. And our natural tendencies as dentists, as you've said, is to explain all of the things that the patients don't care about without addressing the things that they do care about.
Right.
So
exactly right. That's the deal.
So thank you so much for coming on the show. What's the best way? There's the online course. We'll have a link to that. If people are interested in learning more about you, should we send them to your website as well? Just the paulhomoly.com?
Yeah, paulhomoly.com. Everything they need is right there. They can look up the online case acceptance program. I also teach programs on communication and thought leadership. So everything's in one spot right there.
Well, I think I'll have to talk with you offline here in a minute about those programs, because I'm trying to decide which one I want to go to. So
outstanding.
Thank you so much for coming on the show. This was a lot of fun.
Hey, you're welcome, Richard.
Take care. Okay, George, what did you think of that interview there with Dr. Paul Homoly?
I think, he's such a wealth of knowledge and so much experience in this topic of case acceptance. One thing that I've always taken from all of the material I've listened to him on is understanding the patient's awareness and concern of the issue. Understanding, are they aware of the issue and are they concerned about the issue? And so always one of the first things I'll say whenever I, recognize an issue and talk about it with patients is, does this concern you? And if the answer is no, then, I talk about why it's concerning. If it's yes, then, you talk about, this is your next step. And so I think having the patient kind of guide that discussion by asking them questions about issues as if they're facts, as opposed to trying to prove an issue to a patient, I think has been one of the biggest takeaways I've taken from Paul Homoly.
Absolutely. One of my favorite things that he talks about is this idea of right wall dentistry. Like he divides everything into two halves, and there's easier, kind of smaller, simple, less comprehensive cases don't need as many layers of structure and skill built into them to get a pretty decent case acceptance. Whereas once you start doing these more involved cases, bigger cases, there's just a lot of intricacies to it. There's a lot of skills. There's a lot of leadership. There's a lot that the team matters. And so this idea that once you're getting into this comprehensive dentistry, you need to approach this as a whole different thing. And I loved, like, legitimately, if you're listening to a podcast, so you're used to audio, on Amazon, he has one of his books, Making It Easy for Patients to Say Yes, for $9. And it is the MP3 version through Amazon Music. So, like, one of my pet peeves is when stuff is not in a good format. Like, this should probably be on audible.com, but it's on Amazon Music. So it's going to be in like a music app, and you can't save your location. You can't like fast forward it at a higher speed. There's a lot of like pet peeves about like the delivery mechanism for this, but I'm telling you, I don't care. This is such good content for like $9 that I am willing to promote this all day long as like one of the best values. If you just go on Amazon Music, make it easy for patients to say yes. Absolutely fantastic. Any of his books are fantastic. We'll have the links in the show notes for all of his website, for his courses. There's so much here, and I'm glad that we just got a little taste of it today. So anything else that you'd add, George?
Just a reminder to everybody that as we're getting ready to release our case acceptance course, we'll put a link in the show notes to get on that waiting list so that you can get all the updates and when we're ready to launch it.
Cool. Well, this has been another fantastic interview. Hope you guys got a lot out of this. If you like it, please comment on our Facebook page, and we'll see if we can even get Dr. Homoly in on there. Maybe we can give him some feedback and some thank you for all that he's done. So awesome. We'll wrap this up, and we'll talk with you guys next week on the Shared Practices podcast.